Hello, everyone, and thanks for tuning in to Relief's podcast series. I'm Neil Andrews, editor of Relief. I'm thrilled to have the opportunity to speak today with Professor Laura Stone. Professor Stone is an associate professor at McGill University in Montreal, Canada, where she is a pain researcher. One of her main areas of interest is to understand the causes of chronic low back pain, and she does this by using studies in both animals and in people. And today she's here to talk to us about some of her research in this area. Professor Stone, welcome to the podcast. Thanks so much for being here today.
Thank you for inviting me.
So let's start at the top. Can you describe the problem of chronic low back pain? How common is it? How treatable is it? And what are its effects on people and on society?
Well, unfortunately, back pain is incredibly common. It's estimated that up to 15% of the population at any given time will be suffering from back pain, and that the vast majority of us will have back pain at some point in our lives. It is also second only to the common cold, the most common reason for people to visit their doctors. So overall, it's incredibly common. The good news is that in the vast majority of cases of acute back pain, it does resolve within a couple weeks. The problem is for those individuals where it does not resolve, which brings us to your second question about how treatable is it. And for those with persistent back pain, the options are often not sufficient, and there's many reasons why this could be. Um, Back pain can be caused by a lot of different things, and we often don't know in any individual what the driving causes are, so then it's hard to match a good treatment to that individual. And in some cases, even if we knew what the main drivers were, we may not have treatments that can really get at that, or the treatments we have might have side effects that limit their usefulness. There are some options that help people, um, not just medications, but things like increasing your amount of physical activity, increasing the amount of sleep, and decreasing stress, so sort of self-care, quality of life approaches. Many people benefit from yoga or meditation or acupuncture as well. So there's lots of things available to people, but very few things for which there's strong evidence that they will work in most people. Um, so if can I continue?
Oh, yes, please.
Okay, thank you. So you also asked about the impact on individuals and society. And talking about society first, back pain is actually the single biggest cause of global disability worldwide. So there's this amazing study that's done by the World Health Organization and funded by the Bill and Melinda Gates Foundation. And they do this massive global study of all different chronic health conditions and how many years lived with disability they each cause. And back pain is the number one cause in both the developing world and the developed world. So it is literally the single biggest cause of disability in the world. So it just can't be over exaggerated how big a problem back pain is. And on this list of the biggest causes of disability, in the top 10 is also neck pain, which is closely related, migraine, and other musculoskeletal conditions, which is normally referring to arthritis. So actually almost half of the most common causes of disability are chronic pain conditions. So we have a serious impact on society that is just beyond
So, considering how widespread this problem is that you've described so well, why not just go into people? Why study back pain in rodents and mice or in rats? And what are the challenges of studying back pain in those types of animals?
well, we should definitely also we should be studying both. We should study this from as many ways as we can. So studies in patients are extremely important, but there are some things we cannot do in patients, some questions that are better asked in using animal studies. So to give you a couple examples. In in humans, back pain is so complicated because it can be caused by so many different things, and there's um, psychological aspects that go into it, and we all have different genetic backgrounds. We all have different environmental backgrounds. We eat different food. We can control all those things in rodents. So we can have studies in rodents with where we can take genetic differences out of it. We can take them from that they're the same age, they eat the same food, they live in the same environment. So as scientists, this allows us to really zero in on very specific questions that just would not be feasible in a human population. We can also do things in rodent models like induce back pain by injuring a disc, for example, in one of the intervertebral discs in the spine. We can injure that in an animal. We wouldn't do that in a person. So then in the animal model, we could study what the consequences of a disc injury are. What does that do to the animal? Does that cause pain? What kind of pain does that cause? Does that cause other changes? Does that cause changes in their brain? Does that cause them to move differently? Does that cause them to be more or less sensitive to different drugs? None of these experiments could be done in such a controlled way in humans.
So let's talk then a little bit about the specific animal model that you created to study back pain. How did you create this model?
Well, I would love to get credit for creating it, but we found it by accident. So, well, one of the models we found by accident. So the first model we've worked with and what most of our work has been done is we were looking for a rodent model of chronic age-dependent degeneration of the intervertebral discs of the spine. So this is a common cause of back pain in humans where people have either disc degeneration or herniation in their spines. So so we were hoping to find an animal, maybe a species of animals or a strain of mice that had an accelerated degeneration like some humans do so that we could study the impact of that. And what we ended up finding in the literature was someone had developed a knockout mouse that's missing a gene called Spark. And it's a terrible name for a gene. I don't know who names these things, but Spark stands for secreted protein acidic rich in cysteine, which is, that's not a really helpful name, but fortunately it creates an acronym that is pronounceable. So we have these Spark mice. They're missing the Spark gene. And what that happens to do to them is it causes their discs in the spine to degenerate much faster than normal mice. So it creates a situation where we can study this chronic, age-dependent disc degeneration that, like it's seen in humans, but on a much faster time scale. And one of the things that's really interesting about it is that the discs degenerate at slightly different rates in different animals. So just like in humans, it might be that the discs in the lower part of the back are the most likely to degenerate, but in some people it might be a higher disc, or in some people it might just be a disc in the neck and not in the back. And we see that same kind of variability in the mice. So it creates a very human-like situation.
Right. So can you talk a little bit more? So in addition to this disc degeneration that you see, are there other changes that you see, changes in behavior? What else do you see?
Great question. So what makes these mice so interesting is that as their discs degenerate when they age, they become increasingly sensitive to different kinds of stimuli, and we think that they have both back pain in what we call axial back pain, which is pain kind of right along the back region, as well as signs of hypersensitivity in their legs. And that's seen pretty commonly in people with back pain. They'll sometimes have just back pain, or sometimes it'll be back pain and also radiating leg pain, or sciatica is the term often used. So we see signs of both of these things in the mice when we do behavior tests.
So they have both pain and they have discs that are degenerating. So what studies then have you done in this animal model, and what have you found?
Yeah, so it creates the fact that they have disc degeneration and different pain symptoms gives us the opportunity to ask questions about what's the relationship between different kinds of disc degeneration and the different symptoms. So some of the things that we found, one thing that's interesting is we tested a lot of different drugs that are used to treat back pain in the mice, and we found that not all of the drugs work equally on different symptoms. So some drugs work well for the pain in the back region, but may not work well for the leg pain. Whereas there's other drugs that are really good just for the leg pain. So that right there suggests that there's different causes of the two kinds of pain,
Mhm.
even though they're both related ultimately to the discs. There's different causes, so they should probably be treated differently um, in people who have both kinds of pain.
Hmm.
Another thing that we found that we're really excited about has to do with why a disc might become painful. Because normally a healthy disc is kind of like a jelly donut, and it has a mushy, um, compressible center, and then there's a sort of stronger layers around that center that hold it in, and that gives it a nice compressible quality so that the discs can absorb normal pressures that are part of just regular movement. What in normal healthy discs, there's very little, if any, nerve fibers that grow into the discs. So our nervous system can't sense the inside of the discs at all, and that's a good thing because the inside of the discs tends to have a lot of proteins and chemicals in there that, if they came into contact with nerve fibers, would be really would activate nerve fibers. But they're normally contained in the nice jelly part of the disc, so it's fine. But as the discs degenerate, two things happen. One is that nerve fibers start to grow into the discs. So we now have nerve fibers that might be pain sensing fibers grow into discs where they might now be able to sense things that normally shouldn't be sensed. So normal movement that we should not feel now might actually generate pain if there's a nerve fiber that's grown into that disc. The other thing that will happen as the discs start to degenerate is they leak. So now the contents of the inner part that contain all this um, very noxious, nasty stuff, as they leak out, they come in contact with nerve fibers, and that alone will activate pain-sensing nerve fibers and cause pain.
And
So, yeah.
I'm sorry, go ahead.
Well, I was just so the what we found in the mouse model is that as the discs degenerate, there is an increase in nerves growing in, which we do think contributes to the pain. And we've also found increases within degenerated discs of proteins that call nerves towards them. So there's this one protein called nerve growth factor, and like its name implies, it's important in the growth of nerves. So discs that are degenerating, they start to make nerve growth factor, which essentially is almost like a calling card for all nerve fibers in the general area to start to grow into that degenerating disc. So that's a pathology that potentially we can target, because if we can block that nerve growth factor or block those nerves growing in, we might be able to keep that disc not painful.
So some of these changes that you're talking about, I wanted to ask if they could be prevented or reversed. And you mentioned earlier how not the drugs can work on different symptoms. So in addition to drugs, are there other things such as exercise perhaps that could prevent or reverse the changes that you see in your animal model?
Yeah, so it's interesting because if you look at guidelines that are written for clinicians and how to treat back pain, most of the suggested treatments are not actually drugs. Some of them are, but a lot of them are things like yoga or physical activity or acupuncture. So what we did in our animal models was we were really curious if just increased physical activity would help the symptoms, because it really seems to help people with back pain. So we got these little plastic running wheels. They have like a little hut and then a wheel that goes on top. So the mice can build a nest in the hut. It's like an igloo. And they're very cute. And then they have a little wheel on top that runs. So they can run on the wheel. And the mice love it. You walk into the room where the mice are and you just hear because they're running on their wheels all the time, just having a great time. And so all we did was we put these wheels into their home cages, and the animals decide how much they want to run. So we don't force them. There's no stress involved to this. It's totally up to them. We put the wheels in the cages, and the control group for the experiment was the same igloo with the same wheel on it, but we put a screw in it so the wheel doesn't spin. So the mice can still build their nest, and they can still play on the wheel and chew at the wheel and do whatever mice do with wheels, but it doesn't spin, so they don't get the extra exercise. And we just left them there and then started testing them regularly. And we found it took about 1 to 2 months, but we started to see very profound reversal of many of the symptoms of the back pain and the leg pain. So just the wheels there and the mice running whenever they wanted caused a very significant reversal in the pain. And it's not just an effect of acute running, like some people have a runner's high, which can.
Right.
It's not just that, because if we took the wheels away, the therapeutic effect still lasted another month or two. So there's been an actual physical change in the animal because of the exercise that has a really, really serious therapeutic benefit.
And so exercise. So how do these findings then apply to people? So I mean, they seem to support the use of exercise, but of course, people wouldn't be running on wheels. So, um, what kind of exercise would people do? How do the findings like this apply to people, do you think?
Well, we have to be a little bit cautious, right? But we know that any kind of physical activity seems to be beneficial for people with chronic pain. And because the mice happen to have running wheels, because mice like to run, doesn't mean that patients necessarily should run or should swim or ski or play hockey. I think people should do physical activities that they'll enjoy
Mm-hmm.
and that will be not too intense, especially at first, because what we saw in the mice is that it took a couple months before the real benefits started to appear. So if somebody is thinking of starting to increase their amount of physical activity, um, being patient, starting slowly, don't expect to see big changes right away,
Mm-hmm.
but stick to it. Do a little bit every day. Do something that you enjoy. Don't overdo it. Um, those are the kinds of things that the animal studies suggest.
Right.
Um, what unfortunately is often I've seen is that somebody who maybe has developed back pain and hasn't been very physically active for a long time is told to go exercise. But like what exactly does that mean? If you're a 50-year-old man and you haven't exercised regularly for 20 years, we need to give people more guidance. Maybe going to somebody who's a specialist in exercise physiology or physical therapist with expertise in back pain to help you slowly get into a program over time that you'll stick to, and that that you won't hurt yourself in the process. And if you just go and exercise and you haven't in a long time, that will cause pain.
Right.
That's a great way to discourage people from getting into better habits of more physical activity if you do too much too quickly,
Right.
because then it hurts. It makes your pain worse, and then why would you go back,
Right.
right? So we really need to. The best therapists are the ones who help people avoid those barriers of the exercise when you get into an exercise program, of that acute pain part.
Right.
And there'll be a little bit of that, like anytime you exercise, you might be sore the next day. That it has to be kept to the point where you'll be not discouraged from continuing and stick with it for a while, because you might actually be changing your physiology by
Right.
doing it. And can I elaborate on that last point for a second?
Yes, please.
In one thing that we saw in the mice was in the mice that ran for a long time and had their symptoms go down, we looked at their discs and we looked at those nerve fibers, and there was actually a reduction in the amount of nerve fibers that had grown into those discs.
Wow.
With the running. So the running has changed the pathology of the disc that might be causing the pain.
Mm.
But it took a while. So we have to be patient, but just a little bit of physical activity, a little bit more walking every day might actually help reduce disc degeneration, might help cause those nerve fibers to retract so that they're not contributing to pain anymore.
Right. And just one more sort of follow-up question to that in terms of how taking the findings from animal studies to people. When you think about drugs, is the idea that you can see how a drug works in a mouse, and that would be helpful? Is the idea to test new drugs? How do you think about that?
The animal models could be used for both of those things. So we can use it to understand how to use drugs to understand what causes the pain, and to test new treatments. And I'll give you an example. There's in clinical trials right now drugs that target nerve growth factor.
Hmm.
And there are some very exciting results coming out of the clinical trials. There's been some problems that were very eloquently described by William Schmidt, who you interviewed for a similar podcast. So if anyone's interested, you should definitely listen to that podcast. But so because we learned from the mouse that there's an increase in nerve fibers, and that it might be because there's too much nerve growth factor, we treated the mice with an anti-nerve growth factor therapy, and had really positive effects in the animals. So that suggests not only is this potentially a great new treatment to pursue, but it tells us something about the mechanism of what might be driving the pain.
Hmm. Oh, that's great. So in the last part of the podcast here, why don't we transition a little bit from this great discussion about animal studies to people, because you're doing studies in people as well. So can you describe some of the studies that you're doing with patients? And this is in terms of how changes in these intervertebral discs that you mentioned contribute to low back pain.
Yeah, so one thing that's really important when doing animal studies, if we want them to be clinically relevant, it's important to always, whenever possible, take the study to human tissue or to human subjects. So we've been doing a lot of studies with intervertebral discs that are removed from chronic pain patients during back surgery. We're able to obtain some of these discs that we think are the sources of some pain, and study them and see, well, what has changed in these painful discs that is different from discs from people who don't have pain. I've been very lucky to work with a group that with Transplant Quebec to also obtain human discs from transplant donors for control tissue, because it's a problem working with pathological human samples, like a disc that's removed from someone surgically, because there's no healthy disc that's removed. We wouldn't remove a healthy disc, so we need to find control tissues to compare it to in other ways. But what we found using the human discs is we've studied them for all kinds of different biochemical changes in the painful discs compared to non-painful discs. And some of those changes really support what we're seeing in the animal studies and have also driven some of the animal studies. So if I can give a specific example,
Yep.
we found in spinal fluid collected from pain patients that there was an increase in a particular pro-inflammatory mediator. So then we looked in discs from patients and found it was also increased in their discs. We thought that, well, that's really interesting. I wonder if that would be a good potential target therapeutically. So we went back to the animal model, and there was a drug available, an experimental drug, that targeted this particular mediator. So we gave the animals the drug, and it turned out that it reversed many of the pain symptoms in the mice. And it also reversed some of the inflammation in the discs in the mice. So we started with the human samples and then found something interesting and then did a proof of concept in the mice. And now we're thinking, well, how do we apply this back to humans? Are there drugs on the market that could be tested in a small study in humans? Or would somebody be interested in developing drugs to target this?
Right.
So that's kind of an example of some of the value of going back and forth between the human and the animal studies. And if we didn't know already that this was something, that this mediator was potentially really important in humans, the animal study wouldn't have been nearly as important or as interesting.
Right.
And
Right.
since we knew it had clinical relevance, it really made it worthwhile.
Right. It's always great when the animal studies and the human studies maybe synergize, maybe that's the word. Um,
Yeah.
so, in addition to these studies, and you're talking about the intervertebral discs, you also have an interest in biomarkers. So, can you talk a little bit about what biomarkers are and what they may have to do with pain?
Yeah, so biomarkers, this is a term that's used a lot, and it means different things to different people. The broadest way to think of the term is any kind of feature of an individual that might predict how if they have a certain condition, or if they're likely to have a certain condition, or might indicate if a treatment is working. So it could be anything. It could be something found in the blood, like a marker in the blood. It could be brain imaging, different patterns of activity in brains of people with pain might be considered biomarkers for risk for pain, for example, or for different treatments. It could even be your hair color. People with different hair colors might be more or less likely to respond to different drugs.
Hmm.
So what we're interested in terms of biomarkers is mostly has to do with DNA and changes in deregulation of DNA in the blood. So there's this idea that in all of our cells, we all have DNA. And it doesn't change from cell to cell. So your genome and your genetics is what you're born with, and that's what you get in all your cells. But as we go through life, our DNA gets modified, and these different things get added to it, like these different signatures or marks are added throughout the DNA that might change the way that each cell uses your genome to decide what genes to express or not to express. So it kind of changes the pattern. And there's lots of studies coming out now that the pattern of these marks on the DNA changes in different chronic health conditions. Even with depression now, it's been found that in blood, the pattern of DNA marks is different in people with depression than in people who don't have depression. So we did an animal study where we found massive changes in the pattern of these DNA marks in rats that had had leg pain for a long time. So right now we're doing a study in human back pain patients to see if we can identify similar patterns in pain patients. And if we can, then it's the big optimistic goal is that these different patterns might help us predict what kind of pain do you have? What might be the underlying mechanisms for each person, and help us match the right treatment to that person, so that we do the best to help their pain, but potentially even more importantly, biomarkers like these DNA marks or even genetic biomarkers that are that point to risk factors might help us identify people that are about to develop chronic pain.
Hmm.
Like if you have acute pain, most people get better, but a few people don't. If we could figure out by using some kind of biomarker who's most likely to develop a chronic pain, and then really do everything, throw everything we can at that person early with the hope of preventing that transition to chronic pain, we might do more to prevent chronic back pain than we could by all the new therapies for people who already have pain.
Wow.
If we prevent it. So that's the big the big, pie in the sky kind of goal, but that a lot of people are working on ideas like this and making progress. So it's really, there is a lot of hope that we might get better and better at even preventing the development of chronic pain in the first place.
Right. So in addition to these DNA marks, you also had mentioned that changes in the brain might be biomarkers. Can you just briefly describe some of those changes in the brain that you see in chronic low back pain, and are there any studies in this area that you're involved with?
Yeah, so the brain is the first study that really showed that chronic back pain might change the brain was about 15 years ago now by von Yepkarian. And he showed that people who had chronic back pain had different patterns of thickness or gray matter in different parts of their brains, which was a huge kind of game-changing finding, because we never thought before that the experience of living with chronic pain might actually change the brain. Since then, there's been many studies, ones I've been involved in, but many, many studies showing similar kinds of chronic changes in brains in all different sorts of pain conditions, in migraine and irritable bowel syndrome and arthritis, neuropathic pain. So it's definitely a very strong phenomena that chronic pain causes some anatomical and some functional changes in the brain. And those changes, it's thought, might underlie some of the symptoms that come along with chronic pain, like some of the difficulties concentrating, or increased likelihood of developing depression or anxiety. Those could actually be happening in the brain because of the chronic pain, and not just because the person isn't, trying to be optimistic. You're actually changing a person's biological ability to experience joy or to be optimistic.
Mm.
So they're very, some of these changes could be very significant. The good news is that there's now multiple studies, one that I was involved in back pain, but also several others now, showing that if we can reduce the pain even in people who have had chronic pain for a long time and for which these brain changes have already happened, if we can reduce that pain, some of the brain changes can also be reversed. And that gives a lot of hope because it means that we can still recover,
Right.
right? And there's now a study, for example, that shows that even cognitive behavioral therapy, so a therapy that doesn't involve any kind of treatment of the spine or drug therapy, but just cognitive behavioral therapy, learning how to cope better with your pain, learning how to relax, have a more to be more positive, that can change the brain for the better as well. So it's a really powerful thing that we've barely tapped into in terms of the treatments. And one thing that I'm very interested in my lab right now is now that it's pretty well established that pain can cause changes in the brain and that we can modify those changes for the better, I really want to understand what the molecular mechanisms are. And there must be some mechanisms that are able to change the brain in kind of one direction that then when your situation changes, when your pain improves, can change it back to a more healthy situation.
Right.
And getting on the topic of those DNA marks that I mentioned in the immune system and in the blood,
Right.
they're also in the brain. And we've seen big changes in the patterns of those marks in rodent brains from animals that had chronic pain. And some of those changes we think can be reversed with the physical activity.
Oh.
So we're working very hard to identify what those switches are that turn these marks on and off, and if there's a way we can target that with lifestyle changes or with pharmacological interventions or anything that we can learn about how to tap into that mechanism
Right.
might be really important.
And it's very encouraging that these changes that you see can be reversed. You mentioned one of the questions that you were looking at is looking at the molecular mechanism, what explains these changes in the brain. What are the other important questions that you think are still out there about pain and chronic low back pain in particular? What sort of catches your eye in terms, again, of the causes of pain in people with back pain?
I think that the biggest question is why some people develop pain and others don't, even if the amount of injury, say, to a disc is exactly the same. So in terms of discs, it's really hard in a specific individual to link their pain to a disc problem because there's a lot of back pain that has nothing to do with discs. So they're not always linked. And many of us, in fact, probably half of all adults, have some disc degeneration but no pain. So why do some people have disc degeneration and no pain, and others have disc degeneration with pain? Are there biochemical changes in some discs that maybe have a genetic cause that we need to understand, or is that more about the lifestyle of that person, or we don't really know why? But it's a very it's one of the biggest questions is why do some people have pain and not others? If we can answer that question, maybe we can prevent pain.
Right. And are you optimistic that there will be progress on these questions? So are you optimistic in terms of the research that's going on and the research that'll be able to address questions like this? And also in terms of treatment, are you optimistic that there'll be treatments for low back pain maybe in 5 or 10 years?
I'm very optimistic about both treatments and other approaches, but particularly other approaches, and I'll tell you what I mean. So there's a lot of very exciting pharmacological treatments coming through the pipelines. Like I mentioned, the nerve growth factor therapy, but there's other potential new drugs coming along too, and there's a lot of excitement around those. But what seems to also really be changing is the way that people think about what a therapy or a therapeutic course is for somebody with back pain, because it used to just be that you would get a drug and go home. And now there's an increasing appreciation, a lot of it being driven by research, that not just pharmacology, but increased physical activity and increased social engagement, increased getting more sleep, eating better, reducing stress, learning to manage your anxiety better. All of these things should be together seen as a treatment path for an individual with pain,
Right.
instead of just the drug. And there's more and more appreciation of the psychological role
Right.
and the importance of coping and managing stress, managing anxiety. But we still haven't completely incorporated the benefits of increased social interaction in pain management. So, would you let me give a very non-scientific story to end here,
Yeah, we'd love to hear it.
if that's okay?
Oh, yes, please.
Um, One of the best examples of a successful pain management treatment group that I've ever seen is, um, of all places, it is a community swimming pool in a suburb of Toronto called Richmond Hill. And in this community swimming pool, they run aquafit classes several mornings a week. And most of the attendees are older people who have different health concerns, almost always some sort of arthritis or chronic pain. Normally, that's what brought them to the pool, is their doctor telling them that they should go to do this fitness class. And it's run by instructors who are very sensitive to the needs of people who may have different injuries or different limitations. So what's happened in this class, and I know all this because my mother is in this class, is that all of the people who attend the class have started to become friends, and in many cases, very good friends. They started going for coffee afterwards to get to know each other. And so now all of a sudden, you go to the class not just because you know you'll feel better after, but when it's 7:30 a.m. in January and you have to get in your car and then go in a cold pool, what's going to get you there is the fact that your friends are there. People will care if you go. And that's what gets you to the class, beyond just knowing that you'll feel better after.
Right.
And then knowing it's going to be fun and that there's a social component. And it's gotten to the point where the people in this group now, they do all of these, they come from a lot of different social and religious and cultural backgrounds. So they do a lot of outings. They go to the theater together, and they went to visit a mosque once, and they went to visit a church bazaar. And so they do all these activities. And if someone has an injury or has a hip replaced, everybody else helps and drives them to their doctor's appointment or brings food or hangs out with them because they're bored. And if they miss classes, somebody calls and says, "Are you okay? Can we help?" So you have this support, this social support, that what I've seen just in this completely non-scientific perspective is that has had more impact on the lives of these people than any pain medications that they're on.
Wow.
And especially just an overall quality of life, looking forward to things, having people to talk to, people to care about, people who care about you. That's a big thing.
Right. Well, that's great. So to have a fun and the social component to a quote unquote treatment, I think people will definitely be interested in that. That sounds great. So
Yeah.
So there's lots of reason for optimism and lots of great things to look forward to, and I think that's a great note to end on. So Laura, thank you so much for being here today. It's been really great to speak with you, and I know I will and all the listeners will really look forward to following your research in this area in the future. So thanks so much.
Thank you so much, Neil. My pleasure.